Good evening, everyone. Welcome to the College of Allied Health Sciences Virtual Town Hall. Before we get started, just look at the important notes on the screen currently. Everybody's going to be muted. If you have any questions, please type them in the chat box so everything's not missed. My name is Gage Woolley. I'm going to be your moderator today. We are going to record this session, so we will start that momentarily. I think that's already begun. And we will send out a link to the recording in the next few days. So please be on the lookout for that. And that link will include closed captioning as well. Again, everyone, my name is Gage Woolley. Thanks for being here today. I'm currently a part of the College of Allied Health Sciences leadership team. I currently work for Bethany House Services here in town. We are a family homeless shelter. I'm currently the communication special event and volunteer coordinator there. Before we begin, I want to give a special thanks to our College of Allied Health Sciences Leadership Council members, past distinguished alumni who are on the call. We appreciate your ongoing support and your dedication to the college. So thank you so much. Our agenda today includes an update from Dean Whalen about the state of college and the response to COVID-19. I'm just going through the agenda really quick. Following that, we have a few alumni who have agreed to share their experiences in the COVID-19 environment. Social work alumna Miriam Crenshaw and nutrition alumna Suzanne Summers, both past college distinguished alumni honorees, will be speaking tonight. So we're very happy to have them on. We will then answer any questions submitted ahead of time that haven't already been answered and address the questions in the chat box. Again, please make sure you're on everyone and type your question in that way. A few important notes. We will have you all on mute to prevent feedback. We've already mentioned that. If you have any questions for Dean Whalen or our alumni speakers, please type them in the chat box. That's for a third time. We really want to make sure you know that. The town hall will end at 7 p.m. promptly. So if we don't get to your questions that are in the chat, we will follow up with you directly. So with that, I want to go ahead and give the floor to Dean Whalen. Before we do that, I want to do a little brief introduction on her first. So Dean Tina Whalen became the college's associate dean in 2012, but before that was appointed the interim, well, after that was appointed the interim dean in 2014 and then permanent dean in 2015. Under Whalen's leadership, the college has created scholarships in every department, increased grant-funded research projects, and opened the New Health and Sciences building in 2019. She has been a steady and innovative leader as the college and university have been taking the COVID-19 disruption this past year. Dean Whalen, the floor is yours. Thanks for being here tonight.
Well, thank you. Thanks, Gage, and thanks everybody who was able to join us this evening. I wish I could see you all. I know a lot of you guys have your cameras turned off, but I know you're there. I know you're out there in the virtual space, and we appreciate you joining us. So, last year at this time, if we can recall back to February of 2020, I think COVID was not in anybody's vocabulary. We weren't even really sure what that was. I know I was traveling to a national meeting in Denver and came back on February 14th. So that hadn't even happened yet. And here we are, a year later, and boy, what a difference a year makes. I think we can all say that we've gotten a lot more comfortable with using electronic technology to communicate and to have meetings and to have FaceTime and to talk to our children. We've really made a lot of strides, whether we wanted to or not. It was kind of a forced situation, but here we are, and we're happy that we can all be together, even though it is in a virtual environment. So the college has, we've continued to move on. Life moves on, and we keep moving. And so we've learned a lot, I think, along the way. We've been able to apply that learning. And eventually, when we have what we're all referring to as the new normal, I think we're going to take a lot of that information and continue to use it as we rethink how we do higher education in the future. So I just want to share a little bit with you about how we've managed through what I call the COVID interruption. It is an interruption, definitely. It is temporary, although I don't think any of us could have ever imagined how long this would continue on. But I am the eternal optimist. And so I am always saying, there is a light at the end of the tunnel. We're getting closer and closer to that light. We just need to hold on and keep at it. and we're going to get to the other side. And that's how we've kind of approached this whole year in this college. And we do have amazing faculty and staff and students, and they've all hung in there with us. And we've just gotten it done. And that's what we do. And so I just want to share some of the outcomes in terms of where we are, because as I said, life has gone on and we found a way to do it. So student outcomes. I think you all know that in March, middle of March, I believe it was Friday the 13th, we got the mandate that we were shutting down after spring break. We extended spring break for 3 days. So we had 10 days. And then had the students who were living in the dorms come back and basically clear out their stuff. And we launched all of our classes remotely. The university was closed, essentially, to anything face-to-face starting in that third week of March. For our faculty that had face-to-face classes, they essentially had 10 days to get those classes turned into an online learning situation. Our college was blessed and continues to be blessed to have a strong online presence. We had it before COVID. We have fully online programs, and we learned a lot from our online colleagues, faculty colleagues, staff colleagues, about how to make those conversions, the faculty that needed to do so in such a quick time frame. We have a group called our Center for Educational Technology and Instructional Support, and I called them essential workers, and they are essential workers, and they made themselves available to our faculty and staff in being able to make this conversion rapidly and with quality and rigor. So we got it started. We graduated between the summer semester and the fall semester, 395 of our students. We had very few students who were delayed in their graduation because of COVID. We often have students who, because of life or because of not finishing a clinical on time or whatever, may have to push back graduation by a semester. But we were just pleased as could be that the majority of our students stayed on track. We got their courses delivered to them. We got them back in clinical experiences. By May, we had students back out in clinic. And we graduated 395 students by the end of the fall semester of 2020, which was December of 2020. Our first year undergraduate retention rate for fall 2020, we used those numbers from the people who started as freshmen in the fall of 19 to those who then come back for their second year in college in the fall of 2020. We always use a one-year comparison, was over 91%. We felt very good about that, given that fall 2020 was our COVID interruption time. Our spring enrollment for 2021 is at 3,049 students. That's the largest enrollment our college has ever had. We experienced an 8% growth in student enrollment for this academic year. We were one of the few colleges in the university that experienced growth during this COVID year. And it's really testimony to the fact that I believe we're in healthcare, that we have strong programs with great reputations, and we get our students through, we get them graduated, we get them out in the community, and that is what I think makes a difference for our college. So despite this COVID interruption, I'm very proud of these outcomes, and I think that we're well positioned to continue to grow and make this continued progress as we move forward towards this new normal. Could you advance my slide, please? Research. We've mentioned research. When I took the role as dean, one of my first goals was to build a stronger research infrastructure. We have many talented faculty who have great research potential, but you need an infrastructure of support. And that was critical. So we were able to build that with an associate dean of research that I hired first on a part-time basis, and then she became a full-time employee a couple of years ago. We have a grants administrator now, and we've continued to grow our research support, and these are externally funded dollars. So this year, with the COVID interruption, we've already received over $2 million, $2.35 million in new awards just for FY 2021. We still have a number of awards pending, but our faculty are continuing to write grants, to submit grants, and to receive grants, again, despite this COVID interruption. So we're forecasting a research expenditure by the end of this year. In terms of expenditure, we mean new grant support of about $2.5 million. The university is counting on us by 2025 to have annual research expenditures of about $5 million, and we're well over 3.67 now. So I think that college is well positioned to hit that $5 million mark by 2025, if not before. So there we are. We had many faculty that had to, we've used this word and I don't like it, everybody's using it, pivot. In terms of their research, they couldn't do their on-campus data collection activities. Many of their populations have chronic diseases or were at higher risk. And many of our faculty researchers had to change their aims a little bit in terms of their grants to be able to do some of this work remotely using telehealth, do some of this activity in a different format. We have a return to research plan. We started back into that in June. Everything that happens in our building and on campus has to be approved, and I'm the approver for the college, but we take this stuff very seriously from a safety and health of the people that are involved standpoint. So we've been able to keep this research going despite doing it in a little bit different way. And again, without the ingenuity of our faculty and the creativity and the flexibility, I don't think we would have these data outcomes, but we do. And again, it's testimony to the people that we have working in the College of Allied Health Sciences. So the next slide, I only have a couple more. Clinical field, I explained a little bit earlier that we were so fortunate to be able to get our students back to clinic early, mid-May, I would say. So we had a 2-month. I pulled the plug on clinic on March 21st. I worked with 30 some odd people in our college who do clinical placement, figured out when our students who were out in the spring would be finished, try to get as many of them done as possible, and then we just said we can't send any more. And that was consistent with what was happening in nursing and medicine and pharmacy, so it wasn't just us. But then we were really working hard to try to get clinicals resurrected and safely for our students to go back to those clinic experiences so that they could get their practicum hours in, stay on track for graduation, stay on track for progression in their program, be eligible for licensing and credentialing when they graduated, all the rest of it. And so we were able to start that back up in May with our medical lab science program. We started with those students because many of them were in the distance learning program, were employees of the site. So they were able to resume their clinical activities a little earlier. We have a training that students are required to do in PPE, the personal protection equipment that everybody needed to learn about, learn how to use and troubleshoot in the environment. We sent our students out with PPE kits of masks and face shields, and that would even include our social workers, because I said, if they're going to have a face-to-face interview with anyone, they need to have a shield in addition to a mask. So we were able to get them all back. And at this point in time, we've got over 527 students who have either finished or in the process of doing clinical field experience, practicums, rotations. And that was just since the beginning of this calendar year, this spring semester. UC Health has been a great support to us. I think you all know that we are not part of UC Health. They are a partner with us, but they are a separate entity. But they were able to offer COVID-19 vaccinations at the beginning of this spring semester to our students who are completing rotations this semester out in the region. And I got the call on December 30th, and they said, if you can provide us with the list of all the students, we can invite them to be vaccinated. So we pulled that list together in about 2 days. We have a running list. We approve every clinical placement as well. So we have a running list of everyone. So we got all that put together. We also were able to add a few of our researchers who do face-to-face work with chronically challenged individuals to that list. And I believe it was the third week in January, UC Health offered 451 of our students and about 10 of our researchers the opportunity to be vaccinated, which I feel very good about. I know that many of us are waiting for our vaccine and anxiously waiting for our vaccine, but I felt like if we were sending our students to clinic, we wanted to give them that added protection of the vaccine. That doesn't take away their need to wear their PPE, but it gives them an added protection and hopefully helps limit the spread as they then return back to their home and their families after their day in the clinic. So to me, that was essential, and I really am so grateful that we were able to make that available to our students. Okay, I think I might have one more thing. Course planning. In the fall, we had about 13.5% of our classes had a face-to-face component. Those were exclusively pretty much our clinical lab skill classes. Everything else was done in an online format. This spring, we have a little bit more, but we are accommodating that. We have people spread out. We've limited entrance and egress. We have maximum capacity of our rooms, which is about a third to a half of what our normal capacity would be, so that people are 6 feet apart. We're making our students, everybody has to wear a mask on campus. Most of our students who are doing clinical skill type of work are wearing the mask, the face shield, gloves when it's appropriate. In the fall, we had them in gowns. That's now been discontinued because they realized that wasn't essential anymore, but we were having them gown as well to limit the spread and of the virus. So we're getting more students in, still very limited number. Most of our students are in a completely online environment. And like I said, those that are coming in are in a hybrid. They come in for lab and they're doing their lecture and their content sharing and small group work primarily in an online environment. We hope for summer is anticipated. The university has said we are going to do a hybrid summer. So summer will look very much like spring. We have a lot of new professional programs that start cohorts in the summer. So we anticipate bringing them in a hybrid environment, as I've mentioned, we've been doing for spring. And we hope that by fall, we're not going to be 100% back. But with more people having access to vaccine, we're hoping we'll be able to have even more students on campus. Not all students on campus. It's going to be a graduated reintroduction. And we're also hoping that what we've learned through this COVID experience and interruption, that will apply to the new normal. We've learned to do things a little bit differently. And in some cases, we think that it's maybe as effective, if not more effective, than how we did it before. So one of my colleagues said it's not the work you put in the hours, it's the hours you put in the work. So it very well may be that a lot of our classes will remain hybrid even after the COVID interruption is a distant memory for all of us. I think I have an update on our call to action. Is there yep. And in the summer, the college responded to the racial unrest that was happening in our country and the injustices that were happening across the world, but particularly in our nation. And we came together and did a call to action. And the three kind of buckets in our call to action were looking at our curriculum and our individual courses, both in our professional programs and in our undergraduate pre-professional programs, to see where we could add more content related to cultural competence, social justice, health disparities. And we've made some inroads with that area. We added some content to our mid-collegiate experience for our undergrads. We've added it in our first year experience for our undergrads. We're looking at it as it would relate to our healthcare ethics and research methods for our undergrads. In the professional curricula, each of the programs have looked at where they can embed additional information in their courses. Education and training, we have had about 45 of our faculty have participated in training that was offered by our DE&I at the university level called Standing in Solidarity. We did at our annual retreat, which is also virtual. We sponsored Dr. Benjamin Reese from North Carolina to do a 90-minute interactive session with us on systemic racism and bias in the academy. And we're sponsoring ongoing trainings for faculty and staff to be able to engage with our students and with each other in these important conversations. We've done some sponsoring of activities for our students. There was a panel discussion on health inequities, health disparities, if you will, in November as part of Allied Health Month. And Monica Wilkins, our DE&I director, is working with the advisory group to come up with activities that will be student-led in the spring of 2021. So when we did the call to action, we wanted to be able to report out on the actions that we've taken and not just make them things that we said we were going to do. We wanted to say we were going to do them and actually do them, and we're making good progress. This is an ongoing process and will continue to be in our college, but we have a commitment, and we're following through with that commitment. So this has been a big year in many ways, but I'm very proud of the progress that the college has made. So I think that's all I have to say.
Thank you so much. That was a great update. There's so much happening. So thanks for that. Moving on, we have our next guest speaker today. This is going to be Miriam Crenshaw. Known as a hardworking, mission-focused leader, Miriam Crenshaw spent most of her career over the last 30 years as CEO of the Winton Hills Medical and Health Center, also known as WinMed Health Services. It's a nonprofit, federally qualified health center that provides access to quality health care, especially to those underserved and uninsured individuals, regardless of their ability to pay. Under Crenshaw's leadership, WinMed has received national recognition as a model for Cincinnati Public Schools learning centers, and in 2010, WinMed was chosen by GE from 16 organizations as the first and only federally qualified health center in the city of Cincinnati to be a GE developing health facility. And then in 2012, became the country's only health center selected to participate in a GE virtual presentation to Jeff Immelt. That's GE's chairman and CEO, who chaired the President's Council on Jobs. So Miriam, thank you so much for being here tonight, and the floor is yours. Miriam, I think you might be on mute.
Can you hear me now? Can you hear me?
Yes.
All right. I was just saying that it's a pleasure to participate in the town hall this evening, and that I really appreciate this opportunity to share social work experiences during the COVID time. And I would also like to thank our Dean Whalen for all the hard work that she's doing in the School of Social Work pertaining to all the progress that's being made. It's so impressive to see the students and the staff and all of the leaders they're pressing through during this pandemic, and it's just great. I also want to send out a gratitude and a high appreciation to all those working on the front lines addressing COVID, and we send out our prayers and condolences to all those who are ill or who have lost loved ones from COVID. So with that said, I was asked to talk a little bit about the challenges that social workers are facing during the pandemic. And so what I did was I kind of met with our team, and they sort of came up with a list, and I kind of put things together in a format that was simple for you to kind of follow as I just shared with you a little bit about what I learned pertaining to the challenges that social workers are facing, our social workers are facing, and others throughout throughout the country. But I'm going to get started by reading something to you. This was taken from Fox 19 News on January the 13th. And I'm going to make it short, but I'm going to read this to you, and then we're going to talk just a little bit about our challenges. Megan Applegate's family is mourning her loss after authorities say the father of her children killed her. Applegate's brother said she was a strong-willed woman, something she showcased working as a nurse during the pandemic. Her cousin says her heart sank when she heard of Applegate's death and that her thoughts lie with Applegate's 2 children. I'm just so worried about the kids, she said. Just not sure what's going to happen to them. And to make matters worse, the family lost Applegate's mother in November and grandmother in mid-2020. Those kids will be hunted by that for the rest of their lives, her cousin said. They don't have their mom, they don't have their dad, and they don't have their grandma. She continues, I don't know how anyone could kill the mother of their kids to begin with, but hearing this other story is just repulsive. She references the second crime for which Applegate's alleged killer was wanted at the time of his arrest. The warrant under which he was arrested arose from a December incident where police say he put a gun in a woman's mouth and placed her in a deep freezer where she remained for 10 hours before escaping. He allegedly killed Applegate, age 36, on January the 9th at a home in Batavia Township. Her body was found 2 days later. Her children were by her side. He faces a murder charge in her death and is being held at the Hamilton County Justice Center on a $750,000 bond and will be back in Hamilton County Court on February 22nd. January 13, 2021. Dear beautiful staff, it is with great sadness to inform all of the passing of Megan Applegate, one of our most dedicated and most valued members of our Community Action Agency medical team. Megan served at WinMed for almost 10 years and will be remembered most for her kind and gentle spirit. She was a hard worker and highly admired by her colleagues and patients. She will be missed greatly. Please keep Megan, her children, and entire family in your prayers as they go through this most difficult time. Although funeral arrangements are unknown, more information will be shared as it becomes available. Our social work department will be available to WinMed staff for employee assistance as needed for those who may have difficulty with the sudden loss of one of our WinMed workplace family members. As usual, our Chief Medical Officer and myself, we are all available to assist. To Megan's supervisor and to the entire team, we extend our deepest sympathy and encourage all of you to look to Almighty God for strength and peace. Sincerely, Miriam Crenshaw, CEO. So I start out this presentation to you acknowledging that safety is probably the number one issue pertaining to challenges that we not only face as people and human beings during this COVID experience. We talk about masks and gloves and masking up, social distancing, but there's another facet of safety that still remains that must be responded to. With or without COVID, people are still experiencing family problems, personal problems, relationship problems, and we continue to respond to these issues despite what is going on regarding COVID. Issues continue. Safety issues are a big concern right now regarding this COVID pandemic because so many people are forced to stay at home. They're asked to stay at home. They're required to stay at home. And so statistics are showing that because of this, violence, domestic violence has increased, child abuse has increased, and thus the services of our social workers, they're also increasing. So safety is number one. We have to look at the facets of what we're doing as social workers in terms of our duties and our responsibilities. And so as I enter into the next phase of another challenge that I've learned from our social workers at WinMed is that technology And of course, our Dean Whalen talked about how we must shift and change and adjust and adapt and adopt to this new normal. Well, the virtual social worker experience is what has come to be because of COVID. So virtual communication versus physical communication is another challenge that our social workers must encounter. Technology is replacing the face-to-face contact, where we used to be able to observe our clients and kind of see where they are and their facial expressions and nonverbal messages. It's all been replaced, much of it with tablets and smartphones and iPhones and teleconferencing. And other challenges with our elderly, some of our clients just don't have the intellectual ability to navigate the virtual communication scene. And so our social workers are finding it challenging to work with the elderly with their FaceTiming or with their cell phones and assisting them in learning how to operate the equipment that's needed to have the teleconferencing with them. And so gone are the days when our mental health clients could just pop in to our office or just stop by the office, maybe without an appointment, they're just feeling like they need a little help. We don't have that luxury that we used to have then, now because of COVID. It's hard to assess conditions in a home during this COVID pandemic because many are not permitted to go in the homes anymore. And so not only are social workers not going into the homes to make home visits as they used to, but also other healthcare professionals as well. So even though we're considered essential workers, we're helpers, we're case workers. I'm moving into another area pertaining to advocacy. We're therapists and counselors, but we're also more than that. We're change makers. And with the changes pertaining to COVID, we are the forces that must advocate for changes in policies that impact and affect how we do and what we do. So we are the voices of our clients. We are advocates for addressing many of the disparities pertaining to this pandemic. And so we are there for the most vulnerable and most needy populations. Now, moving into your needs as a clinician, as a social worker. Many social workers are working from home. They're caregivers in their own home, and they're having to face illnesses and even death with their own family members. And so there's often boundaries between professional and home life that can easily become blurred. And this causes additional pressures when it comes to the social work and challengers during COVID. So these social workers who are also family caregivers often neglect eating properly and getting the proper rest that they need themselves. And so we find people overeating and snacking and taking in junk food. They call it comfort food, resulting in poor nutrition and weight gain, while many of their clients are facing problems regarding food security, not enough food, and going to the free food banks and pantries and soup kitchens. So there are other challenges that the social worker they're facing pertaining to ensuring that their clients have the basic essential food that they need. So the challenge of navigating resources for all types of services is there. Resources for food or other means for meals for children no longer in school with free lunches. Much of that is being resolved by the creativity and other means and other sources. But there's even medical appointments, and the social workers are dealing with clients who are afraid to go to the doctor's office, afraid to sit in the doctor's office, waiting room, feeling that they may catch the virus. How do you talk to your clients when you're trying to schedule follow-up referral, but they're refusing to comply? Resources for transportation are being made by our social workers, and often attempts are being made, but our clients are afraid to ride public transportation. Learning and hearing of stories where the bus driver contracted the virus and passed away, and they're concerned about public transportation. So we find people with no jobs, no food, no transportation, no rent, evicted, sleeping in cars. afraid to go to a homeless shelter or a battered woman shelter because you got 2 kids and can't get COVID because who's going to take care of the kids? So there's a lot that our social workers are having to adjust and to shift and to change in terms of service delivery. And many times they're talking on the phone to their clients and they're wondering about confidentiality. The babies are crying and there's all kinds of environmental distractions. Is it a confidential discussion? Who else is in the room listening? And where are you? Oh, you're in Kentucky. Ethical issues. You're in Kentucky. I'm in Ohio, and I'm not licensed in the state of Kentucky. There's all kinds of issues. Why didn't you tell me you were in Kentucky? How long have you been in Kentucky? And I thought you were going to be in Ohio. There's all kinds of anger, all kinds of emotions pertaining to fears, anxiety, guilt, additional pressures from loss of loved ones, depression, sadness. And then one of the most recent is the vaccines that Dean Whalen was talking about. So many myths and confusion about that vaccine, especially among the African-American communities where there's medical mistrust and delayed treatment because of miscommunication and suspiciousness about taking the vaccine. There's so many disparities that are blatant right now in the midst of COVID that we must respond to. And the disparities include housing and low-wage employment or none at all, and other health issues, as well as lack of housing. So in closing, there is hope. It's a new normal. We must acquire a new attitude. We've got to be more creative about finding other means. As Dean Whalen said, we got through it, we're getting through it, we're adjusting, we're changing, we're learning, we're growing. We must have an attitude of overcoming and muster up the courage, the confidence, and the strength. We must trust God and pray. But as often shared with me, faith without works is dead. So with all the challenges that our social workers are experiencing, that it's so different from the way we were previously trained to work and to serve, it's important for us to just stay connected. Stay connected. I think the pandemic has put so many people at a pause for reflection and for preparation and for planning for change. So in closing, I just want to say that we must stay connected. For me, it's important to stay connected to God. It's important to stay connected to each other. We must keep working together, keep partnering for better outcomes, keep communicating with each other, keep educating each other, our employers, our governors, our government representatives, our professors, our every partner that we have. We need to share, and having the door swing both ways and explore and keep talking and planning and evaluating and keep connected. And staying connected will help combat the many challenges of this pandemic.
Thank you so much, Miriam.
You're welcome.
Wonderful to hear all the things that are happening and the stuff that you and social workers are doing to really make and change the lives of folks here in Cincinnati. So thank you. The next person we have up is Suzanne Summers. Suzanne Summers is a passionate servant leader in the nutrition field and in her community. She began her career as a began in dietetic research after graduating from UC in 2001 and completed an internship at the National Institute of Health in Bethesda, Maryland. In 2003, she began working at Cincinnati Children's Hospital and Medical Center as a bionutritionist in the Clinical Translational Research Center, where she now serves as the Nutrition Research Manager, using her expertise as a registered dietitian trained in epidemiology to implement the center's nutrition research initiatives. She earned a master's degree in epidemiology in 2007 from UC, and her work in the field fueled her to complete a doctoral degree in epidemiology in 2020. She currently serves on the board of directors for the Greater Cincinnati Dietetics Association and the National Association for Research Nutrition. Thanks so much, Suzanne, for being on tonight.
Thanks, Gage. Brianne or Bree, can you advance the slide? So first, yeah, thank you, Gage and Dean Whalen, for inviting me to share my experience today. And also, I want to thank Miriam for sharing that powerful message. And I'm so sorry to hear about your colleague. I really am. That was shocking. And my thoughts are with you and your team. So I am a registered dietitian, but my specialty is clinical research rather than direct patient care. And my team and I collect nutrition and body composition data for all kinds of clinical research studies. So I can definitely speak to activity on the front lines of research during the pandemic. Well, like many other operations, research was essentially shut down from mid-March through the end of May. Now, in our research clinic, we have over 100 active research studies, but during that time, basically, there were just two types of human research permitted. There was COVID-19 related research, so we're talking about vaccine development, treatment development, diagnostic testing, and epidemiologic data collection. And then studies not COVID related, where the participant would basically be at risk if they did not do the study because the procedures might be related to their safety or their treatment needs. For example, if they have a timed treatment like a drug infusion that has to be done, those studies are still allowed. Beyond that, all other research should be conducted, and I quote, remotely or not at all. Now, this affected things like enrollment targets and timing of study visits, of course, but it delayed startup for new studies, which was a huge burden on funding. For example, if you can imagine, you have a big NIH grant. It's due to start in July, and you've hired staff, and you've agreed to pay a % of effort for your collaborators. And then the study's put on hold and funding is stalled. And how do you pay these people? This is a real concern for a lot of researchers. Or on the flip side, your funding begins on time, but your whole study is delayed. And then you have that problem on the back end where your study keeps going and you run out of funding. We began our research recovery by about June. So really looking back, it was kind of a short time in the whole scheme of things. And we slowly ramped back up to normal research study visits and procedures. And I guess what struck me in the early stages of that recovery is that things were kind of in a feast or famine mode. So on the one hand, you had entire study teams that were virtually without work for months. While you also had programs that conduct vaccine trials, and they had to move fast to build staff and capacity to implement trials like the Pfizer, Moderna, and other vaccine trials that you've heard about. Likewise, in the hospital, elective surgeries were on hold, and outpatient clinics drastically reduced services or closed entirely, while you had others who were very busy preparing for an onslaught of admissions of patients with COVID-19. So you had people on this side scrambling to fulfill their hours and avoid loss of jobs, and while you had others who were just overworked and burning out. I can say by now things have settled down a little, and we seem to be stable under this new normal, as we like to call it. I guess if I had to find a few bright spots in all of this, on the research side, I'd say for one is that some staff learned new skills because they left their normal work environment to try to backfill those busy operations. And as I'm sure you're aware, and Miriam alluded to, and so did Dean Whalen, we greatly accelerated our use of virtual platforms, and that has been helpful. Use of telehealth has grown by leaps and bounds. And even in research, we've been testing out remote visits where possible. Things like questionnaires and interviews can be done remotely. That's not an issue, but very physical things. My best example would be, say, a blood draw to collect a sample for a research study. Obviously, you can't do that virtually. But there are some physical components that are trying to adapt. And a good example is recently, my group does a study where we do body measurements like waist and hip circumference. And we've begun piloting remote measurements where we send the measuring equipment, which is really just a measuring tape and some clothespins, to the participant. And then we schedule a video call and we guide them through doing the measurement on themselves. And so far, I'd have to say that's gone pretty well. It's not something we ever thought we would be trying to do. I could go on. Those are just a few observations that I've had for how the pandemic has impacted clinical research. And if Bree, if you could advance to my next slide. Okay. And just to switch gears to patient care, as I mentioned, I am certainly not working on the front lines of fighting COVID-19 as a dietitian, but through our local and national dietitian networks, I've learned just a few things that dietitians are dealing with that I found pretty fascinating, and I'll share those with you. So nutrition at first glance may not have a causal role in development of COVID-19 and certainly isn't going to cure it, but here are just a few basic facts about nutrition and COVID-19. First of all, comorbidities that increase risk or severity of the disease, such as diabetes, heart disease, and hypertension, all of these have nutrition as a very strong contributing factor. And second, having an overall healthy eating pattern over the long term of your life may help prevent chronic illness. We know this. And in the case of an infectious disease like COVID-19, it can surely help you fight the disease or at least reduce severity of symptoms and maybe even avoid hospitalization. For example, several nutrients are involved in the growth and function of immune cells, like vitamin C, D, zinc, selenium, and iron. And having nutrient stores like these, along with energy storage in fat and muscle tissue, helps you when your body is in distress, when you're hypermetabolic, meaning you need more than you normally would. And that occurs during trauma and fighting illnesses like COVID-19. But notice that I say nutrient stores. Early in the pandemic, I heard stories about vitamin C flying off the shelves, people taking it if they thought they weren't sick with COVID. Unfortunately, that's not how it works. To me, that's like locking the gates after the enemy is already inside. Really, having an overall eating pattern in general ensures that you have those stores in place before disease strikes, and that's what's really going to help prevent becoming ill. Or if not prevent becoming ill, it may help you pull through if you do experience some of those more severe symptoms of COVID-19. And lastly today, and this is way out of my wheelhouse, but I attended a wonderful seminar that was hosted by the local Greater Cincinnati Dietetic Association, presented by Michelle Koznicki, who's an inpatient dietitian in Milwaukee. A couple of important lessons that I learned from her presentation about really providing nutrition therapy on the front lines. First, it's important to note that obviously COVID-19 didn't exist before, and we had no recommendations for nutrition therapy. So dietitians and other clinicians had to develop these in real time based on published research and proven strategies for similar conditions. And of course, these approaches also had to factor in the goal of minimizing exposure to the provider team. And so that adds an extra layer in an already complex situation. As an example from the nutrition side, if the patient required tube feeding, they preferred to do continuous feeding versus bolus feeding. And that just minimizes exposure to the provider. The person has to come in and set the feedings up and take down. They also had to figure out how to perform a nutrition assessment remotely. So at times the dietitians weren't allowed in the room. So they had to figure out how to do this maybe on a video call or talking to family members. And one aspect I found really interesting is the prone positioning of COVID-19 patients. So you've probably heard that these patients do better when lying on their stomachs. It takes pressure off the heart and makes breathing easier. But imagine trying to feed someone in this position. So dietitians have figured out that they can deliver tube feeding to patients in the prone position, and it works just fine. A few adjustments are needed, so they have to elevate the head of the bed as much as 25 degrees to reduce risk of aspiration. And then something you might not think of is the patients are occasionally turned over onto their back, and when that happens, the feeding tube can become dislodged. So that's something they had to be careful for. I guess what really struck me was all the little things like that need to be considered when you're in a new and unique situation like this. Again, looking for bright spots here, I think one is that the important lessons they learned about feeding in the prone position, the necessity for enhanced collaboration with the healthcare team, because the dietitians, the ancillary care people aren't allowed to go in the room. Maybe only the nurses are allowed to go in the room. So you need to work really closely with your nurse team or your physician to make sure that they can deliver the nutrition information that you need or gather information from the patient for you. But I'm very proud to say that when given sufficient resources, dietitians and other healthcare experts really can and will problem solve in these types of situations to ensure the best care. I know we're about to wrap up, so that's all I wanted to share today. And just remember, nutrition is important in both sickness and in health. Thanks.
Wonderful. Thank you so much, Susan. That was a wonderful presentation. I actually started off as a nutrition major and then switched to social work. So I kind of had both things in college, and it's nice to hear about both of them. So thank you. Now we're going to go ahead and go on with our question and answer section. Currently, we have two questions, but if you do have any, please type those into the box and we will ask them. The first one is actually going to be for Dean Whalen, and that is actually how are the students handling remote learning and dealing with COVID protocols in general? Like, what's your general feeling on how they're handling those?
Well, thank you for that question. So, I think that there's definitely, I pull things down during Miriam's presentation in particular. I think students, and this is a kind of a glossy way to say it, but I think a lot of our students are missing that sense of community that we all miss. I think Miriam spoke to that as well, right? I mean, there's a lot we can do virtually. We've learned to do a lot. We're able to deliver our content. We've been able to figure out how to get them together in an environment in the lab and keep them safe and learn those clinical skills. But that sense of community, that being able to just like talk to people in the hallways. I mean, we have them come in, we have them leave for those who are even able to. And so I think there's an acute sense of community. We've been working really hard on trying to, with our faculty, find ways to create a little bit more of that in an online. That's one of the other reasons why we're bringing a few more groups in this semester. We can accommodate that, and they're missing it too. Some of these students just started their cohort in the summer, and they've never actually met each other. So we're looking for opportunities to get them together, even though it's very limited and very sterile. So I think that sense of community is certainly lacking. I do believe there's a higher need for mental health services and stress. I think a lot of people are feeling that. Miriam made that very obvious to all of us, but I think our students are feeling that as well. And we hear about the COVID fatigue. I think that's really real for everyone, but we're seeing that in our students as well. Some of them have started as freshmen. I mean, what a weird freshman year, that ended with a weird senior year in high school if you're a traditionally aged student. And I think they're feeling that effect and that stress pretty acutely, some of them. So that's what I would say about that.
Thank you. Let's just stick with you then, since there's another question that kind of focuses a little bit on COVID. Have any of our students in the pharmacy school been asked to help out with vaccine rollout?
So that's interesting because when UC Health made vaccine available to us, the dean of our College of Pharmacy asked whether or not that they could help, and meaning I think students and pharmacy faculty, with any of the vaccination. And I can only speak to UC Health, but I would say that UC Health said, no, we have it kind of a well-orchestrated plan, and it's going to be done this way, and so we don't need your students. Now, those students were offered vaccine as well as our students were, and the College of Nursing students and the medical students. We do know, though, that all of our students are out in clinics. So whether or not some of those students are helping to vaccinate where they are located now in practicum, that very well could be happening. But as far as helping to disseminate vaccine at UC Health, they're not. And the University of Cincinnati as an organization has no vaccine because, as you know, all the vaccine is disseminated through the health systems, not through universities. So we have no vaccine. We were just very thankful that UC Health made it available to our students who were going to clinical practice or practical field service kind of things.
Great, thank you. So there's one other question currently, and this one's for Miriam. So it is, what CE training topics or resources could the School of Social Work Alumni Board, what kind of topics could you provide them for the social workers at the school? I don't know if we can hear you, Miriam. Okay. Don't think we can hear you still. So if you do,
Can you hear me now?
there we go. Yes, we can.
All right. What was the question?
Yeah. So the question was, what CE training topics or resources could the School of Social Work Alumni Board work to provide for our social workers?
Well, I think there has to be more emphasis on leadership among our social workers. And I think that is very important because the role of the social workers, consideration for other areas of service is being highly considered. When you look at the social unrest rather in our communities throughout our country, there's been so much talk about violence and police intervention and the role of the social worker, or the role that the social worker may or could play in minimizing violence during an investigation. So I think that a course that might be needing to be considered is leadership. We need social workers who have some leadership training and interested in entering into the field of leadership and administration, so that they can be on a level that they can impact change and that they can influence some policy and decision making regarding the role of the social worker as it changes and shifts based on society and what's going on at the time. So I think that needs a lot of attention. The other one that I think would be helpful for social workers would be a course pertaining to contributing factors of racial disparities. The COVID problem has impacted on communities of color, African Americans, Hispanics, Native Americans, Asians, and I think it's important for our social workers to get a greater grasp on the contributing factors pertaining to the disparities among our various cultures. So there are a lot of health issues, heart disease, asthma, diabetes. There's disparities in occupational, financial vulnerability, low-wage employment. There's disparities regarding housing, affordable housing, multi-generational housing, tribal, close spaces and living quarters. And I think it's important for our social workers to be able to clearly identify the contributing factors pertaining to racial disparities and be well educated about them so that they can assist in responding to them effectively. So those would be the two that I would suggest right now.
Great. Thank you so much. And with that, that is our last question for the evening. If you do have other questions, still please put them in the box and we'll make sure we get those answered for you. We do appreciate everyone. Thank you so much for being on tonight. I was going to say to be mindful of the time. Let me make sure I didn't miss any notes here. One final note, the Social Work Alumni Board is offering a CE training on grief on Tuesday, March 16th. We will honor this year's distinguished alumni on Monday, April 12th, ahead of the annual Praised Research Conference. So thank you so much for your participation and support from the college. We'll be in touch and look forward to seeing you again. Thank you so much.
Thank you, everyone. Thank you, Gage.